patients with severe disease. So our vaccines will provide us with some protection. So Omicron was first described in Botswana and then shortly thereafter in South Africa. And the fact that it was so early in its description and picked up is a scientific success. It's a success of the investment that our country has made in science. South Africa and the world now needs to convert that scientific success to a response success. And as you've already heard, the last thing we need is panic and overreaction. And certainly what we've seen in knee-jerk reactions is really uncalled for. And we've dealt with variants before. It's not new. Our country has dealt. We've been among the first to describe variants before. So we know how to do this, including how to deal with variants with immune escape. Closing the borders has almost no benefit. Well, no benefit for two reasons. As of yesterday, there are already 11 countries reporting cases of Omicron. So, trying to isolate South Africa or even Southern Africa is not really going to help, because pretty soon many other countries are going to become avenues of spread of the virus. But more importantly, we have existing 5-step strategy that actually does very well in reducing travel transmission risk. We already know how to prevent and reduce the risk through travel. And that's by ensuring that only vaccinated people travel. You do symptom screening at boarding. You ensure they have a negative PCR result at boarding. You have a mask during the flight. And lastly, as I've just seen, having gone to France for the meeting at the Pasteur Institute, you get a COVID test on arrival. That is the way in which we can protect ourselves. You can add in, additional requirements like quarantine, self or mandated, but we can deal with this. Just at a time when we have a new threat in this pandemic, when we should be standing together against the virus, we end up, standing against each other. We end up putting fences between us instead of dealing with this and understanding what the enemy is and how that we need to tackle it together. So there are 3 things that, I believe need to be done to deal with this virus, and our response needs to focus on that. The first is we can expect that higher transmissibility is likely. And so we're going to get more cases quickly. We're already seeing early evidence of this. And if that happens, the cases concerned, I'm expecting we'll top over 10,000 cases by the end of the week per day. We'll see pressure on hospitals within the next 2 to 3 weeks. And even if Omicron is not clinically worse, and certainly the anecdotes don't raise any red flags just yet, but we don't know for sure, we are going to see this in all likelihood because of the rapidity of transmission. In a way that in which we saw with the Delta variant, a very rapid rise in cases and huge pressure on the hospitals in Gauteng. Our public health measures work, so let's use them. Mask wearing, ensuring that we follow all the rules. I won't go through them right now, but things we know very well. And then finally, our biggest challenge is going to be to prevent super spreading events that will just put us out of control, and to ensure that we reduce the risk of transmission, particularly indoors. And to do that, even though we're likely to see more reinfections and breakthrough infections, the vaccinated people will have they are less likely to have severe COVID. And so one of the things is to restrict risky situations, particularly indoors, to vaccinated only people. And that's part of the strategy and the direction in which we should be heading. On that note, Minister, thank you very much. I'm sorry I have to leave you, but I hope that was helpful.
Thank you very much. Thank you very much, Prof. I'm sure you leave us with a very capable team, which will take us through further and answer the questions. And keep your phone on silent. If we get stuck with some difficult question, we'll WhatsApp you and, and you can. But I'm sure we've got a very capable team here which can deal with those. But this is not the end, as we say. This is a marathon. It's not a sprint. So as we go through this marathon, we will always tap on your knowledge and experience. Thank you very much. Back to you, Foster.
Thanks, Minister, and thanks to Dr. Karim for that comprehensive presentation. Without wasting any time, we're going to get a presentation on epidemiological update as far as this variant is concerned. I believe Dr. Michelle Groom is going to give us that update. Over to you, Dr. Michelle.
Yes, sure, thanks. Just trying to share my screen. Can you see my screen faster?
Yeah, we can see the screen, Michelle.
You can see. Just
Thank
put
you.
it on
Oh, yeah, I'll put on,
mode.
yes. There we go. Thank you. Is it fine now?
Yeah, I can just put it. Oh, yeah, no, it's fine.
Okay,
wonderful.
Great. Good morning, Honourable Minister and colleagues and viewers. So I'm just going to give you a brief update, I think just in terms of where we are in the epidemiology. So this is really just our lab confirmed cases. And you can see we'd actually, towards the middle of November, had the lowest case numbers that we had seen really at any point since we had started the pandemic. We talk about the 7-day moving average, which is really just to even out the number of cases that we see on a daily basis. We know that often over the weekends that we see slightly lower cases. And so the 7-day moving average gives us a good indication of this. And so in mid-November, this was less than 300. And you can see that we have seen a rather rapid increase in terms of the number of new cases. We were sitting at the 7-day moving average of just under 2,000 at the moment. We also have a look at these are the number of tests in the bars. So you can see that the testing that we were doing during this period after the wave, very similar to what we were doing between the second and third wave. And the one metric which we really use is the percent positivity, which is the number of new cases each day out of the total number of cases of tests that were done. And you can see our positivity rates were also at the lowest that we had ever seen, since the start of the pandemic. At around 1%. And you can see there's been this rapid increase in the percent positivity over the last 2 weeks. Just looking at this by province. So the blue here is Gauteng. So you can see most of this has been driven by case increases in Gauteng, but we have also seen increases in Limpopo, Northwest, and Mpumalanga. In terms of the age groups, so towards the end of the third wave, we saw quite significant increases in our younger age groups. At this stage, a bit difficult to see in this graph. I'll show another one now. We can see that this has been driven mainly by our younger age groups. And this is really a factor of that the younger age groups are really those that are more likely to congregate, more likely to go out and socialize, and thus similar to the second wave we saw last year, very much started in these younger age groups. So if you look at the percent positivity by age group, once again, you can see most of this is driven by the under 25-year-olds, but we do get spread now to the other age groups. And so while the increased number of cases were initially found in several of the tertiary education centers in Tshwane, you can see that we have now spread into the other age groups. In terms of sex, I think we have had a very similar pattern between males and females, slightly increased incidence in each of the waves in terms of females, but this is cases and may just be that females are more likely to present to health services. But at the moment, no significant differences between males and females. So just to focus on Gauteng province, because this is really where we have seen the increasing cases. Very low case numbers mid-November. We were seeing about less than 100 in terms of our 7-day moving average. And this has now crept up to about 1,500. So I think most of the increases in our daily case numbers at this stage are from Gauteng, making up about 80% of those cases. And very similar to our national picture, we can see really driven by the 10 to 14-year-olds 20 to 24-year-olds, 15 to 19-year-olds, and slightly in the 25 to 29-year-olds. And I think really striking that, at the beginning of November, we had very, very low positivity rates. And so there has been this tremendous increase in the last 10 to 14 days. So I think I'm going to stop there and just hand over to one of my colleagues, just to update in terms of hospitalizations. So this will be Dr. Jassat.
Good morning, Honourable Minister and to colleagues and members of the media. I'm going to carry on from where Michelle stopped, just to give you an update, particularly focusing on the Tshwane resurgence that we're seeing, and giving you an update on hospital admissions over the last few weeks. So as you know, DATCOV is a hospital surveillance system that was developed by NICD and the National Department of Health. And we currently have 408 public hospitals and 258 private hospitals that report COVID-19 admissions to DATCOV daily. When we look at admissions, the 7-day moving average nationally, after the peak of the third wave, we saw a decrease to low numbers, and we're starting to see a slight increase nationally. And what we see on the right is that the increase is evident in both the public and the private hospital sector. When you look at the daily average of admissions in the current 14 days and compared to the previous 14 days, we can see that there have been significant increases in Gauteng from 18 admissions a day to 49 admissions a day in the past 2 weeks, and a small increase in admission average in Northwest. But the other provinces are still not yet showing increases in hospital admissions or deaths. Let's go to Gauteng now. On the left, you can see the number of cases in orange and the number of hospital admissions in gray across the 3 waves. And you can see the sharp increase in cases and admissions now, since week 45. On the right, we track the percentage of cases that are admitted. And usually during the peaks of the waves, a lower proportion of cases are admitted because only the very sick get admitted. And after the waves, we tend to see a higher proportion of cases admitted. So currently, we're still seeing a very low proportion of cases admitted. However, when you look at the week-on-week change, you can see the very steep rise in the week-on-week change in cases, and similarly with admissions. And acknowledging that admissions always lag by a week or 2 after cases, you can still see, compared to the first 3 waves, a very sharp week-on-week increase in Gauteng in this 4th wave. Looking at Gauteng's admissions, you can see in this resurgence an increase in both the public and the private sector. And on the right, you can see the number of admissions by district, and you can see the earlier increase in Tshwane Metro, and then you can see the other districts starting to increase. Thankfully, for now, we're not seeing any increases in deaths in either public or private sector and in any of the districts. And when you look again at the current 14-day daily average and the previous 14-day daily average, specifically for districts in Gauteng, you can see now that all districts have shown an increase in daily admissions over that period. The biggest increase being in City of Tshwane, and the other districts showing small but steady increases. Now on to Tshwane Metro. In the last 2 weeks or so, we've had about 455 admissions, of 253 in public sector and 202 in the private sector. 8 people have died, 200 have been discharged alive, and 219 are currently admitted. There's been a very sharp increase in admissions in a few hospitals, with the highest numbers of admissions, particularly increasing in the last 10 days or so, in Tshwane District Hospital, Steve Biko Academic Hospital, Jubilee, Medforum Private Hospital, and Mamelodi Hospital. When you look at the numbers of admission by age, and this is 1-year age bands, you can see that what we normally see is a large number of admissions in older people. But in this early resurgence in Tshwane, we're seeing most admissions in the 0 to 2-year age group, a large number of admissions there. And we're seeing a large number of admissions in the middle ages, sort of around 28 to 38. But when you look at the incidence risk of admissions, where you divide the number of admissions by the population size, you can see that the highest risk of admissions is still in the very oldest, the over 65s. And it's been increasing in all age groups over the last 6 weeks. This is the percentage of cases that are admitted by age age group. And so you can see that the percentage in the middle ages are quite low. Less than 10% of cases are being admitted, but very high proportions of young children are being admitted. And of course, as we'd expect, higher proportions of older people are being admitted because they usually present with more severe disease and are at risk for more severe disease. Looking at the percentage of admissions that have comorbidities, as we would expect, most of the older groups have comorbidities and are admitted with COVID-19. The percentage of younger children admitted with COVID-19 with comorbidities is quite low. This is the percentage of admissions in Tshwane with severe disease, and you can see that it's higher in the older groups, and in the younger groups under 60, it hovers around 25 to 30%, which is what we've seen across the rest of the pandemic. There's been very few deaths, just 8 deaths thus far, but you can see most of the deaths have been in the older groups, 60 to 69 and over 80. Now, this is the proportion of admissions that are severe in Tshwane Metro. And as you can see that during the peaks of the waves, we have a higher proportion of patients who are admitted who are severe. And after the waves, that decreases. Currently, the proportion of patients who are admitted with severe disease are quite low and lower than what we've seen across the rest of the pandemic at about 60%. And just to zoom in on the last 7 weeks, you can see we've had a sharp increase in the number of patients admitted with not severe disease compared to the number of patients admitted with severe disease. And just finally, this is very incomplete data, but I thought worth sharing. In all the admissions in Gauteng, about 25% have known vaccination status in DATCOV, and you can see the vast majority of patients, new admissions and the current inpatients, are unvaccinated people, with a much smaller proportions of patients admitted being fully or partially vaccinated. I thank you for your time. Let me just go through a quick summary. We've seen increased admissions in Tshwane Metro, both in the public and the private sector. We are starting to see increases in other districts in Gauteng in hospital admissions since the past week. There's a sharp week-on-week increase, and that's important to note because for surge preparedness, we know that when the hospitals become overwhelmed very quickly, there's less capacity and there's more mortality. And so we really need to look at surge preparedness, both in Tshwane Metro, the other Gauteng districts, but also the other provinces. The increased admissions we're seeing in young children under 2 could be just precautionary. We don't have enough information yet, but the indications are not that they're more severe than they have been in the past. But I think what's important for us to note is that while we do hospital surge preparedness, this time we may need to look at pediatric bed preparedness especially. It doesn't look at the moment as if there's any signal towards increased severity, but it is early. Admissions do lag by about 2 weeks after cases, and it takes some time for patients to have an outcome. So I think this is something we'll watch and hope to give more information in the coming weeks. And interesting also is that most admissions are in unvaccinated individuals. Thank you very much for your time.
Thanks very much, Dr. Wasila and Dr. Michelle Groom, for that input as far as the epidemiological report is or update is concerned. On that note, I'm going to swap my presenters. Instead of getting the clinical observation from Dr. Unben Pillay, I'm going to call upon Dr. Kongwana from Gauteng Health to give us the state of readiness as far as the province is concerned in terms of facilities, oxygen, ICU, and the likes. So I'm going to hand over to Dr. Kongwana. Dr. Kongwana. Doc?
I'm switching on my video.
Okay, and just also adjust your camera so that people can see you. You are
See
live
me.
on TV, the camera TV are, but yes, now we can see you.
Yeah, okay, thank you very much. And Mahali, I was going to send a presentation, but apparently it's not coming through, and I'm not familiar with this system of Zoom, but I will engage with everyone. We currently in Gauteng have 4,407 functional beds. Remember, Gauteng Health has got 18,344 beds prior to COVID, but this number of 4,407 407 were the beds that we had at the peak of the third wave. And we decided as Gauteng Health that we will take these resources to the fourth wave. It is from lessons learned. When we started with the third wave, we were at about 2,000 beds, and we have what we call a risk-adjusted, demand-informed strategy. So as the peak of the third wave went up, we increased until we came up to 4,407. We decided from the end of the third wave that we are going to continue to monitor these beds that we have been allocated to COVID-19, the 4,407, and these will be our resources that we will take to the fourth wave. So we have been preparing for the fourth wave since the end of the third wave. Secondly, with security of oxygen, during the third wave, we had daily meetings with our folks where we monitored the bulk oxygen tank, even during the riots, including the cylinders, the availability of the oxygen cylinders. And we noted during that period that the oxygen cylinders are strategic in us managing the pressures that is there in terms of patient care. So we are currently having a meeting with our folks on a bi-weekly basis. And when the fourth wave hits us, we will go back to our daily meetings. We also developed a WhatsApp where we daily monitor what is happening in the facility. So in terms of security of oxygen, we can boldly say we are secured, because that's exactly what we went through the third wave, and we've been monitoring that throughout. And we intend to take the same strategy and approach for the fourth wave. In May 2020, Gauteng did not have specific COVID-19 posts. We had a staff complement of about 68,000. As we speak at the moment, we have a staff complement of 6,000 for the COVID-19 contracted personnel. And this contract ends at the 31st of March 2022, and we have submitted to our principals that we need that this post continue for the financial year 22-23 in terms of sustaining stability and also lessons learned. We have a cohort that have currently is experienced in managing COVID-19. We're not dealing with variants in terms of when patients come into our facilities, we're dealing with individuals. Of course, the information we have received from Prof. Salim and all the other experts in our country help us to actually have an attitude that says we need to defeat this COVID, irrespective of the various variants that it presents with. So we are prepared. So we have moved from 68,000 last year. Currently, we've got a staff complement of 81,000. Remember, we are not the Department of COVID-19. We are a Department of Health. We still have to deal with the other healthcare needs of our population, of our communities. So we still need to redress and address and manage whenever a patient presents in our facilities. We've got 4 academic hospitals. Charlotte, we're happy that it is functional, even though not to an extent that we desire due to the fire, but the expertise that are there are highly appreciated, because remember, the first patient in South Africa was managed in Charlotte, who was diagnosed with COVID-19. So the expertise of Charlotte remain very, very critical for us as one of the 4 academic centers in Gauteng. We've got 3 tertiary hospitals, and we've got a number of regional hospitals and district hospitals. We have about 38 facilities in Gauteng, and about plus minus 300 clinics that we have in Gauteng. So the attitude we also are maintaining since the decline of the third wave is to constantly monitor our PPE that we do with supply chain, the security of water, the security of power supply. We're monitoring our generators, the security of waste management, the security of laundry services, the security of pharmaceutical supplies. So we are constantly monitoring those key issues because they are very important in making sure that our experts, that is our staff in the forefront, in the trenches of fighting COVID-19, are well supported. We also are noting on a regular basis the issue of the psychosocial needs of our staff. Because when you have a war, you have to make sure that your soldiers are looked after very well. And if there is security of oxygen, there is security of PPEs, there is security of power supply, security of water supply, that makes the battlefield more aligned to us winning over COVID. We cannot deny there are challenges. And the other issue that we have is we need to reassure our communities that we are ready for COVID-19, fourth wave. It's like the cricket staff, the cricket team of South Africa, the Proteas. If they're going to play England again, we cannot judge them in terms of their losses to England. We have to have confidence that they are going to do their best with playing cricket against England. We have played or battled and combated COVID-19, the first, second, third wave. We're ready to combat it for the fourth wave. It's lessons learned. We have a dashboard that we monitor our beds on a daily basis. It is live. We check it every day. We're monitoring also our ABTs in Brongospruit, in Josh Mukari, in Bara, in Anglo Ashanti, as to the occupation of those facilities. So we have bed capacity. We have a continuum of still employment, of engagement with our HR to make sure that we still fill up the 1,000 beds that are needed, not 1,000 beds, the 1,000 posts that are still needed to enhance the battle and combat for COVID-19. We are collaborating with our expertise, public health specialists. We are collaborating with our emergency medical services. We are collaborating with academia. We take every note very serious. We're collaborating with our communication systems to make sure that information that is sent out in the community is information that is reliable, in order for us to mitigate against doubts, mistrust, and any aspersions that are thrown to us healthcare systems. Let us reassure our communities that we have very dedicated and very, very committed healthcare workers in our systems. People that are experienced and very committed. The 81,000 healthcare workers in the Department of Health are committed to face the fourth wave as we have faced the third wave, as we have faced the second wave, including the first wave, in the interest of making sure we win. Nobody will ever really tell us exactly how it's going to behave when it hits us, but we are prepared as we are ready to make sure that we respond. Our approach, risk-adjusted and demand-informed strategy will still be implemented. In the concept of highly reliable organizations, you create redundancy, you create a common mindfulness, and you create checklists, which we have at the moment, and we are monitoring on a daily basis the admissions in our hospitals. We are monitoring our 4407 dedicated COVID-19 beds in our hospital. We are accessing all the systems, your EVDS, your DATCOV, any system that is being presented to leverage the combat of COVID-19. These are resources that are available to us as the Department of Health in Gauteng. And one of the key issues in highly reliable organizations, you defer to experts. And we have got expertise in our academic hospitals, in our tertiary hospitals, in regional hospitals, and we have the confidence that they will take clinical decisions in order to increase this base from 4407 to a figure above 4407. It will be a risk managed approach, clinical risk, because what is key for us is that when a member of our population, a citizen of our country who is not well, needing healthcare attention, when they come out of our hospital, the outcome should be better. We have to reduce morbidity, we have to reduce mortality, but we must present to ourselves, to yourselves, that we are ready. President Nelson Mandela indicated that the brave do not necessarily are people who are not afraid, but they're people that will manage their fear. So we will manage our fear against the Omicron or any other variants. We will remain focused as we face the third wave, the turbulence that the fourth wave is bringing. But we have the confidence, as we have been able to collectively and collaboratively manage the third wave together with the resources that were there, the South African National Defence Force that was there, the Doctors Without Borders that were there, the WHO, and all the the partners that have been available as resources for Gauteng Department of Health will be deployed collectively, collaboratively, to really combat the fourth wave. So, Honorable Minister, honorable members, and respectable colleagues, this is the synopsis of where we are as Gauteng Department of Health. We are aware of the sort of a level of mistrust that exists in our communities, but we have gone through 3 waves, and we're confident that we will go through the 4th wave, and we will make appropriate decision in time for whatever curveballs or deviations that the 4th wave will present, and we will respect and depend on science and depend on the resources that the Gauteng provincial government has provided, and the remarkable support we are receiving from the NICD, from the National Department of Health, and all other partner departments that have been working with us to make sure that the citizens of Gauteng, the citizens of South Africa are well looked after when they come into the facilities in Gauteng. We have been having ad hoc collaborations with our private sector colleagues in Gauteng. We will sustain those collaborations and engagements. We learn from one another, and we will continue to do that. But the last message that I have for my dear brothers and sisters in our communities is that let's not panic. I'm repeating what Prof. Abdul Salim said, let's not panic. Yes, we are afraid, but we are going to manage our fears and remain focused, use science, the resources we have, knowledge to respond and combat the 4th wave of the COVID-19. That was predicted prior that it might be taking place in December. If you are into it now, we will continue to monitor and take appropriate steps to respond to COVID-19. We want our people to be safe and alive. Thank you very much.
Thanks very much, Dr. Khongwana, for assuring us that as far as the province is concerned, you are ready for any eventuality. So without wasting any time, I'm going to call upon our panelists who's going to give us clinical observations as far as the patterns, the symptoms is concerned. That's Dr. Unben Pillay. Somebody was asking me through the WhatsApp. I'm referring to Dr. Anban. So here is Unben, but you can correct me if I pronounce the name very well. Over to you, Doc.
Thank you, Foster. No, the pronunciation is perfect. It's Unben Pillay. Honorable Minister and Deputy Minister, good morning, and colleagues. I'm a general practitioner in private practice in Gauteng. And from our side, what we've seen is very similar to what the scientific panel have presented. Is we've started seeing increases in cases for around about 10 days now, with a very sharp increase. Prior to the 19th, I think, majority of general practitioners' cases were down to 0. In the general practitioner space, the cases are very mild, but it is early days. So we've seen patients present with flu-like symptoms, dry cough, fever, night sweats, and a lot of general body pains and malaise. And I think this is in keeping with all the other COVID waves that we've seen. We haven't seen a vast and a big increase in hospital cases or in pulmonary complications. But again, I think this is really early days for us as general practitioners. Generally, the cases that we see in private practice are milder cases. But as the waves and the hospitals fill up, we start seeing a lot of the complications. I think the general practitioners are very aware of how to manage patients. We've been doing it now for 3 waves. We have done a lot of upskilling in the last few days as well for general practitioners, so that we are aware on what needs to happen in terms of management and treatment with the 4th wave. But overall, I think our cases that we've seen is also positive cases in both vaccinated and unvaccinated cases. I think the vaccinated patients, definitely, we're managing them at home and we're managing them symptomatically. They tend to do much better. And we are at the moment starting to see this increase. And so we will know a lot more in terms of what the patient's presentation features are, or I think as we go along. Thank you, Foster.
Thanks for your very brief presentation, Dr. Pillay. Now I'm going to call upon our colleague from the Department of International Relations and Cooperation, Mr. Gleason Munyela, to share with us as far as international traveling is concerned and how the department is assisting in that regard. Over to you, Mr. Munyela.
Thank you very much, Foster. And let me also acknowledge the Honorable Minister and all the other experts that are in the meeting. And good morning to members of the Fourth Estate, as well as to South Africans who are following this briefing on television. Let me just start, Minister, with a case that we were dealing with in Mauritius, because I think that's the most urgent one, given the number of calls that we received from families here at home inquiring about the plight of their loved ones. So what happened is that there is a plane that took off from South Africa to Mauritius when it was airborne en route to Mauritius. I think a decision was taken by the authorities in Mauritius then to impose mandatory quarantine for South Africans. This was taken hours after the takeoff, I guess taking a cue from European countries. The update, however, with regards to the plight of South Africans in Mauritius is that all of them have been processed. The tourist groups, if you can call them that, have been sent to respective hotels for purposes of quarantine. And the cost of this quarantine will be covered by the government of Mauritius. Resident permit holders have been sent to facilities owned by government in Mauritius for purposes of quarantine. Now, Minister, we've also just been informed by the Republic of Mauritius that they've decided to apply further arrival restrictions on flights arriving from South Africa with immediate effect. So as of Sunday, the 28th of November, and until further notice, there will be no incoming passengers on flights connecting from South Africa to Mauritius. We think it's important for South Africans to know this, so that if you're planning to travel to Mauritius, you may want to look at other options. We've also, Minister, received reports of some South Africans stranded in other capitals around the world. Now, we would like to urge South Africans who may be in similar circumstances to please contact the nearest embassy in the country where you may be. There is a team, Merola Embassies, to assist South Africans who are stranded and render the necessary consular services. Those who are not able to perhaps get contact numbers of our embassies, if you visit the DERCO website, we've listed all the contact numbers and emails of all the embassies abroad. We've got quite an extensive footprint globally of over 124 missions. The alternative, if you still are unable to access that, would be to call the DERCO headquarters here in Pretoria. We've got a 24-hour operational center, and the number there, if I can just say it here on this platform, is 012-351-1000. You can call us around the clock. Our consular services team is on standby to render the necessary consular services to South Africans who may require this. Let me just then conclude, Minister, by making this point that it's quite regrettable, very unfortunate and I'll even say sad, to be talking about travel restrictions imposed by a fellow African country. I have since seen that there's about 3 other African countries that have also taken this decision to impose travel restrictions on South Africa and other countries in Southern Africa. The minister and the scientists in this platform have already articulated why this decision is unwarranted and unjustified, because it's not based on science. The president, His Excellency President Cyril Ramaphosa, also made this point last night. We, as the Department of International Relations and Cooperation, are engaging all the countries that have taken this decision. Minister Naledi Pandor is talking to her counterparts at the level of diplomats. We're also engaging all these countries with a view to persuade them to reverse this decision. In the context of African countries, I think the point must be made, Minister. You and Minister Pandor and the government pay me to once in a while take off the diplomatic hat and communicate things that must be said. And after I've done the damage, you can then come in and say, no, this is just an official of government. As ministers, we will say something different to temper the language. Because what I don't understand is that some of these African countries that are doing this know the struggles that as a continent we have, where European countries will take this decision and impose these travel bans. And the immediate effect in the context of South Africa, for example, is that you are then putting a hold on tourism. Now, the tourism industry is a potential catalyst to the economic recovery that we seek to see in our country. The UK, for example, remains one of the largest sources of tourist arrivals in South Africa. So when the UK imposes a travel ban, it has that impact on our country. So when a fellow African country does this, especially in the context where most of these countries are beneficiaries, South Africa has just made a substantial donation to donate vaccines to a number of African countries. And I see in the list, some of these countries who are imposing these travel bans on us are going to be benefiting from that. It doesn't make any sense. And that's why we think these decisions must be reversed immediately. So for our part, Minister, I'm going to conclude by saying that we are engaging, and we are hopeful that given that we've got very solid and cordial relations with all these countries, we consider them to be friends and partners. We believe the discussions will take place within the spirit of that cordial nature of our relations, and we should be able to resolve these matters. For South Africans, please call us when you need assistance. We've got a team that's on standby 24/7 to render the necessary consular services. Thank you very much.
Thank you, Mr. Emiela, for that presentation as far as traveling is concerned. Somebody was telling me that South Africa was being punished for being honest. So we don't know what to do. If you're honest, you get punished. You keep quiet, you get punished. So on that note, I'm going to open questions and answer session. But before I do that, I'm sitting with a number of questions, almost more than 15 questions. What we'll try to see how can I summarize them. But before I read out the first batch of questions, I'm going to check with Minister if he wants to make any other summary based on the presentations by all the panelists. Minister.
First, just to thank all the contributors. I think this has been a very useful engagement. We thank the richness of the input from the first one from Prof. Karim, the clinicians, the epidemiologists from the NICD, Dr. Pile, Dr. Khongwane, and also finally Mr. Munyela. I think this is information which we believe that at this time of need, all South Africans want to be assured that we are on top of the situation, and those who are in distress have somewhere to can call. And I think this is quite appreciated to the contributors we can deal with the questions. Thank you very much.
Thanks, Minister and members of the panel. I'm going to take the first batch of questions, which read as follows. The first question is from Catherine from Times Lives. It reads as follows. How many people who have tested positive for COVID-19 have been vaccinated? How many people who have tested positive for COVID-19 have been vaccinated? Number two, PCR tests have been abandoned worldwide from the 31st December 2022. What's going to be used then? Rapid antigen test. The second question, or the third question from Tamakan Business Day.
Sorry, Foster, can you just repeat that one? It says PCR will be abandoned from when?
Yes, according to this journalist, the PCR test will be abandoned from the 31st of December 2022. It's almost a year and a month from now. So she's asking if we're going to start using the rapid antigen test in the absence of a PCR test. Tamakan from Business Day is asking, many countries have introduced vaccine mandates for healthcare workers. Why hasn't South Africa done so? Is it not something that we plan to do in future? Patricia Visache from SABC wants to know, when exactly did we first become aware of this variant? What is the benchmark for the country South Africa to be considered to have entered the fourth wave? What was the benchmark for entering other waves except the cause of the first wave? Lastly, from the same journalist Patricia, compared to other waves, is there a concern that could be more severe wave than the third wave? If so, why not? Lastly, can you talk us through the government's thinking on how the new variant was introduced? There's been a lot of criticism that we have not determined how transmissible or severe this variant was and the cause of travel bans. I think I can take this batch of questions. I think they're more than enough for the panelists to respond. Then I'll take another batch.
Just repeat that last one. I'm not very...
The last question reads as follows. Can you talk us through the government's thinking on how the variant was announced? There's been a lot of criticism that we have not determined how transmissible or severe this variant was and the cause of the travel bans. You want to say bans? So the cause of travel bans. I'm not sure if you understand, Minister and the members of the panel.
Okay, I'm trying to just think. Okay, I hope
she just wants to know, in fact, in summary, she wants to know whether the way we introduced this, we announced the variant, we've been criticized for this. So are we happy with the way we announced it? Because now this was followed by a huge criticism from the international community, who have, some of them who have ended up banning us for travel as far as travel is concerned. I'm going to stop here, then I will allow the members of the panel to assist each other to respond to this before I take the second batch of questions. Over to you, Minister.
Yeah, thank you very much, Foster. Dr. Crisp will help me in this, in terms of who will be best to deal with what. Let me just say, in as far as the issue of mandates, including health workers, I think it's from Tamara Khan. As was announced by the president, the whole issue of mandates, the cabinet and on the recommendation of the Coronavirus Council has agreed that our net joints formed a team which has been looking at this. Net joints is a committee made of heads of departments. Now they've got a small team which is working specifically looking at the introduction of a formal introduction of mandates. Our approach as government thus far has been to say that we will not have mandates determined centrally by government, but we will support any sector of business, civil society, institutions of learning, any institution which decides on a mandate either for its staff or customers or clients or if it's a learning institution, staff and students, and that we will support those who take such a decision. And that's why we developed the vaccine certificate, which we have been improving its quality and reliability and security. So that's really, there's been our approach, but at current, what the NCCC and Cabinet have decided is that the net joints must come with concrete proposals on how to phase in mandates. Look at what kind of areas of activity, it be in the social activity, business, and so on. So that include workplaces. So the team will come with firm proposals, which will include also health workplaces. So that's what I can say about that one. In terms of how do you determine when you are in a particular wave, Dr. Crisp, I'm sure together with colleagues from the NICD will assist us. There's a scientific way in which we look at the positivity, the constant in the 7 day, 14 days, where it is constantly, and they will be able to talk to that. The question of the criticism about how the announcement was made, we were guided by the fact that we are part and parcel of the world community under the United Nations, under the World Health Organization. There are particular conventions in terms of international health regulations, which bind all member countries, that when you, in your country, you discover something which, is a threat to life, not only to your citizens, but also possibly to other citizens of the world, whether it's Ebola in West Africa, whether it's an outbreak of typhoid, or any other disease, all this, especially infectious diseases, we are obliged in terms of international health regulations to report, so that the WHO as a leader in terms of health in the world can alert member states and citizens of the world that this and this is happening, and we can take necessary precautions. So we did exactly that. Now, of course, we know that there are many South Africans who are feeling that maybe we're too much in a hurry to announce the fact that this has been discovered, and because if we had kept quiet, possibly the travel bans would not have happened. But that would have been very detrimental, because you don't want, our approach is not to have our citizens live in false security and false safety. And like some of the world leaders have taken that kind of route. So that really remains our approach until a different decision can be taken. Can I invite Dr. Crisp maybe just to help me to see the other scientific and health epidemiology matters?
Thank you, Minister.
Okay, over to you.
So, thank you, Minister. And good morning to everybody. I suggest that we ask Wasila and Michelle from NICD to talk about how many tests who have tested positive are not vaccinated. There was a slide shown, and we are able to monitor this over different time periods, but they can talk about what we are seeing at the moment and maybe expand on what has already been shown on the slide. NICD can also respond on the PCR and what we use different PCRs in South Africa, and they can talk about why and what with the PCR going forward. The question about whether we are seeing more severe disease, and if we're not, why not? We don't know. And I mean, I think that is what the clinicians said. At the moment, it may partly be due to the fact that a larger proportion of the population is vaccinated now than in any other of our 3 waves. So we did expect that doesn't matter which variant we'd have, there'd be some protection from the vaccination. but also protection from the wild infection that we have seen during those 3 waves. But I'm sure the colleagues from the NICD can expand on that as well. How a variant is introduced, well, that's also speculative because, as we heard from Prof. Karim, viruses mutate all the time. So whether this virus actually mutated here or elsewhere and found its way here with one person is entirely speculative. It's a very difficult and long exercise, as you will have gathered from the initial investigations in China, to try and establish exactly how a virus mutates and becomes aggressive or starts to be transmitted in a community. Again, they may want to respond to that. When did we become aware? The labs phoned me on the 24th of November. Now, we had all been watching the increase in numbers for 2 weeks. And what happens is the labs, when we see a change in the numbers, all become alerted to see what the variant is and how the tests are behaving. And so on the 24th was the first time that our laboratories were able to definitively show that what they were already picking up had a particular gene pattern, and that gene pattern was notified to us on the 24th. And on the morning of, that was the evening of the 24th, and on the 25th, we were able to convey all that information in a meeting with a couple of government ministers, including the health minister, and then later in the day to the president. So we knew on the 24th and government knew on the 25th. The question of the 4th wave is rather academic, and I'm happy if the NICD colleagues would like to go into that. But I think we've been discussing with them yesterday and overnight about when do we actually say that we've entered the 4th wave. Technically, there's a definition, as the minister said, where you count numbers and moving averages and a number of other issues. But I think we can safely say we will head into the 4th wave. So it's purely academic about whether Gauteng is actually already there or not there. It's a question of time, and this is what we expected would happen round about now. But with your permission, Minister, I think if I can hand over to Michelle and Wasila, they will be able to answer the other questions. Thank you.
Thanks, Dr. Crisp. And so just, I think to speak to the vaccination status, so the NICD holds the case data, the hospitalization data is within the DATCOV system. And so we are linking in the EVDS data, which is collected by the National Department of Health in terms of being able to classify vaccination status. And so going forward, we would be looking to integrate that information into our daily reports. Dr. Jasat can give a little bit more details just in terms of the hospitalization data. Just to comment on the 4th wave, I think the previous 3 waves, we have definitely, there's been a lot of emphasis in the public domain in terms of these classifications of the waves and whether we're in a wave or not. And as Dr. Crisp has highlighted, I think the technicalities are really, we should not harp on those in terms of these definitions of exactly which exact date the wave is. We've seen an increasing the number of cases in Gauteng. For all intents and purposes, Gauteng has entered the 4th wave. We're seeing high positivity rates. This is most likely going to extend to the other provinces. And I think we need to, in terms of our plans for dealing with the resurgence, whether we're in a wave or not is not going to affect those. And in terms of the public, I think we need to be vigilant in terms of the non-pharmaceutical interventions, the mask wearing, paying attention to social distancing and avoiding large gatherings, as at any stage of seeing increasing number of cases. And it should only be when we're technically in a 4th wave. I think I'm going to hand over to Dr. Anne van Gotberg just to please just expand on the PCR testing, and I think can also just give a little bit more information in terms of that initial detection of the variants. Thank you, Prof. van Gotberg.
Thanks, Michelle, and good morning to all at this press conference. So I've written down 3 questions that I could tease out that I could answer or have some information about. I think the approval in 2021 that is being withdrawn by the CDC is simply the withdrawal of the emergency use approval. They want formal, full approvals that are for all other PCR reagents. Remember in the pandemic early in 2020, things were happening very, very quickly. And in order to get registration of PCR tests, there was so-called emergency use authorization. And the FDA and throughout the world, people are saying we have many commercial tests. There's no need for emergency use. And many of these commercial tests are all fully authorized now at SAPRA and FDA and other international organizations. So that's the 31 December deadline. Is a screening of travelers failing us, the PCR screening, and I don't believe this is the case. I think the force of infection, the number of individuals that might be infected in South Africa is quite high. We saw that increase, the numbers increasing so quickly, and I think they were incubating. So I'm hoping these are still all the tests and laboratories that we are doing routinely. We know that they all work. Even if there is this one dropout, we would still call them positive. And so what is happening is there are individuals who are incubating and they are negative 3 to 4 days later. Remember, they were tested as they arrived and they had a 72-hour frisk from the previous test. So more than likely, this is what's happening. It's simply a reflection of the force of infection here in South Africa, in Gauteng, the very province that many of these travelers must be living in. And we need to explore exactly what other reasons there might be for that high number of individuals that tested positive. But I don't believe it's a failure of our laboratories to detect the SARS-CoV-2 virus. In addition, there was something about Botswana did independently identify one of these sequences and they loaded it onto the global web page, database that's called GISAID. Because it was only 1 or 2, I'm not sure if it was still small numbers and it was quite unusual with the many mutations. They didn't notify, they don't have to notify us in South Africa, and they didn't. In fact, they knew that they had found this, it had been loaded, but it did need additional sequences for us to really think, oh my goodness, something is happening. So a day or two later, South Africans loaded their sequences, so we loaded from the NICD and from AGSA the sequences, and it's the information together that was independently detected and loaded onto GISAID that then made us all talk together, Botswana and South Africa, the scientists. We were speaking together, and then this information also helped because the numbers were greater from South Africa. We were seeing this increase, so there was the epidemiological data that made us report to the government here in South Africa and then subsequently report globally. I think those were the questions that I could see that I could assist with. Over.
Thanks. I'll try and respond to a few questions relating to the hospital data. As Dr. Groom shared, we have some data on vaccination status in DATCOV, the hospital surveillance. And just looking at the Tshwane increase amongst the patients where we do have information on admissions, 13% were vaccinated or partially vaccinated, and 87% of admissions were unvaccinated. Also, we've been tracking this over the past few months since February, and what we can see across the country is that there's a much higher risk of death amongst those that are unvaccinated. But of course, as we get a better linkage of our case and hospital data with the EBDS, we'll be able to share this going forward. There were a few questions about how many admissions were related to the new Omicron variant. So we are currently busy with linking the hospital data to PCR data, because there is a signal on the PCR that indicates which ones are the variant and which ones aren't. And so once we do that and we do the linkage, we'll be able to compare variant versus non-variant and their outcomes and severity. And hopefully soon we'll be able to report more on what proportion of admissions are related to the variant and whether there's more severe disease related to the variant. There was also some questions around pediatric admissions increasing. So I just want to emphasize that, we vaccinate to protect us as individuals from severe disease and death, but we also vaccinate to protect those around us, particularly those who can't vaccinate. And given that children under 12 can't vaccinate because they're not eligible, and we saw in the third wave as well, a shift towards more admissions in children. We're seeing slightly more admissions at the start of this resurgence in children as well. we're not sure if it's related to the variant circulating and a higher transmissibility. We're not sure if it's because of the immunity gap with more older people already vaccinated and so younger people being a bit more susceptible. But what we do know is that vaccination of the adults around the children will likely protect the children from spread as well. And then finally, I wanted to make a comment. There was a question around preparedness at the community level. And the NICD and the National Department of Health and CHI did an audit of mortality in hospitals with high mortality in the second and third wave. And one of the things we found that the patients that died in the hospitals were those that were presenting very late. They were already quite sick and they were dying within the first day or second day of being admitted. And so I think it's very important, you're quite right to point out that it's not just hospital preparedness, but we need to look at community preparedness, preparedness of the GPs and the primary healthcare clinics so that they can monitor and refer early those patients who are at high risk, the older patients with severe comorbidities, and also get the message out there to people not to delay presenting to hospital if they have severe disease. And so, yeah, I think a very important issue raised around not just preparing hospital capacity, but preparing for management of patients in the community. Thank you.
Thanks very much, our panelists, for responding to those questions. Now I'm going to take the second batch of questions, looking at the time. The second batch of questions reads as follows. Brian Sokutu from Citizens is asking if there's no scientific basis for the travel ban. Could the decision by the Western countries be informed by politics or racism? How hopeful are we to reverse this travel ban? Even though this sounds political, but Minister and the Deputy Minister can assist in this regard. Andrew Meldren from Associated Press is saying, what are the key areas where vaccine mandates will be most effective? The third question, how many of those who have tested positive have been vaccinated? I think this one has been touched on. Charlotte Kiwan from EWN, what do you think the chances are for those countries or nations that have imposed bans reversing their decisions on us? Have the nations or the government already engaged with these countries who have imposed the travel ban on this? I know Mr. Mnyala has touched on this, but he can also assist in this regard. Another question from Sophia from AFP. President Ramaphosa and Dr. Karim have both said the variant was first described in Botswana. Could you please explain what does it mean and clarify the timeline that led to the announcement of this on the 25th of November? Kawela Maholeko from UFM is asking, if vaccination campaign messages by the department or the vaccination campaign messages by the department refers to the fourth wave that is approaching, what evidence does the government have as far as the fourth wave, which is anticipated that will be coming anytime soon? Is there no evidence? If there's no evidence, how far or how is that not fear mongering by the government? Or by your own admission, the government, there's not enough information on how the new variant will manifest itself. Why is government using to tell its vaccination campaign in the process of creating an impression that taking a jab will protect one against the COVID-19 and all its manifestation, including this new variant? Another question from Wendell Rolf is directed to Dr. Yazat, or anybody who can respond. Did I hear correctly that there's been no death from this new variant yet? I know I've seen on the chart that the colleagues from NICD have tried to respond to this, but for the benefit of these journalists and others who are watching through other channels of communications, can they assist to respond if there's any death which has resulted from this variant so far? Christian Duplessis, I'm going to take this as the last batch of questions. I mean, the second batch. Christian Duplessis from News 24 is asking, is there increased hospitalizations in those between 0 and 2 due to this variant? I want to check if there's any increase with hospitalizations for children between 0 and 2 due to this variant? And should the parents be concerned if there's such? How many people have been hospitalized or died during due to this virus, Omicron, so far? The last question from the same journalist, so far, what are the most common clinical symptoms reported on this variant? And these symptoms, are they severe or less as compared to the other variant, the Delta? Lastly, when will the booster shots be made available in public, and which age groups will be receiving these booster shots? I'm going to hand over to the panelists. If there's any question which I did not read it well, feel free to let me know so that I can be able to repeat it. I'm going to hand over to Minister and members of the panel once more to respond to the second batch of questions. Will be, in fact, yeah, this is the last. The other one, if there is, maybe should be the matter of follow-up questions that I see on the chat. But for now, I'm going to hand over to Minister and members of the public, of panel, to assist in response to these questions. Over to you, Minister.
Thank you very much, Foster. Unfortunately, I think we will need to make this the last because we still have other matters to attend to for the day. So I think, yeah, we'll try and deal with this. And then in terms of, I think Mr. Minyala could come back, but the question from Brian, and then I think there was another one along the same lines as to whether about the motivation for this travel bans and whether there's a chance that they can be lifted and whether we are engaging. I think really we leave that to the motive. We can only leave to those who made those decisions. But our own suspicion is that it's an attempt to try and give a false sense of security from this pandemic to the citizens of those countries by thinking in a very simplistic way that if you have closed airports for people from particular countries, it's like this virus, it's kept in some container in those countries and carried by the citizens of those countries. So if you stop them, then nothing will happen. But we know that as many scientists and have said that by the time this is revealed, from experience, by this time, we know that it is, by that time, the virus is already all over. But also, as we can see, even after this announcement, as it has happened before, positive tests of the same variant are being discovered in various. So we will continue to engage. And as I've mentioned, even yesterday, I had that engagement with the Secretary for Health of the US. And as Mr. Munyala has indicated, Minister Pando is also engaging counterparts from all those countries and other countries. So we'll continue to engage to try and show them the senselessness of this particular action. And because we didn't close ourselves out of the world, they did so. We will really just hope that sense will prevail, and sooner rather than later they will see, the wastefulness or lack of sense of what they've done. I'll just pick up on, there was one there was somebody who said that we have, by our own admission, that there is not enough information. Why are we using the variant to somehow to campaign for vaccination? Well, the issue of the rise in infections, whether it's which variant or that which variant, whichever variant, the fact of the matter is that as the infection rates rise, it's just a reminder to us that this virus remains deadly, remains in our midst, and all that we're doing is to motivate our citizens that you should, utilize what is available, tried and tested in terms of prevention of serious illness by being vaccinated. It's not in any way trying to scare people. It's just a reminder that we do have the tools which can save our lives, and those tools are tried and tested, and the and all, the fear around the variant should not actually drive us into despair, because we do have tools, non-pharmaceutical, the health prevention measures, but also we do have a biomedical tool to help us to avoid, if we do get the virus, to have milder illness and possibly not even get the illness. But if we do have a milder illness and not end up in hospital. So it's not in any way taking advantage, but it's essentially making people aware that there is a way in which we could protect ourselves. Let me as I'm looking for, I think the others, can I just call Dr. Crisp again? And there might be an area where you might be able to also find a way where in some of the areas, I think there was a repeat, although it had been explained by the team from NICD about the virus founding in Botswana and so on. And I thought Prof. Tulio could also say something just to add to the NICD. But let me leave it with Dr. Crisp just to see which other, as we want to conclude, which other questions can be taken by who. Over to you, Dr. Crisp.
Thank you, Minister. So I'll answer the ones that I feel comfortable to answer, and then I'll pass on the others to others. The question of deaths due to the Omicron, I think, was already explained, that we are still typing and getting an indication of which of the diseases are caused by Omicron, but that can be repeated by Wasila in a moment. The percentage of vaccinated people who test positive, I saw there was a correction of the question. So we've got 16.5 million people vaccinated in South Africa. So that's over 24 million doses have been administered to people. And it's a very small number of those people who have been diagnosed positive. Literally, very, very small. So to correlate back and say of all those vaccinated who's test positive, I'm sure we'll be able to do it with time, but it's minute in comparison with the unvaccinated people. The key areas where mandates might be effective. So I think people misunderstand the mandate story. So at the moment, we in South Africa have mandated non-smoking in South Africa. So when I was a younger person, anybody could smoke anywhere, any place, anytime, in the movies, in the airplanes, in motor cars, houses, shops, anywhere, while they're doing their grocery shopping. We now have mandates that says you may not smoke in those places. We didn't say you may not smoke. We said you may not smoke in those places. So you still have a choice to be a smoker, but you have to comply with where you may and may not smoke. You can't smoke in the workplace, for instance. So I think that people need to understand it perhaps in that context, that when we get this working group to finally make recommendations, which we hope to work very hard on this week, that's the kind of thing we expect. In such environments, you will be required to prove you are vaccinated. Otherwise, you can't enter that environment. We're not saying you have to go and get vaccinated. You might just have to stay at home and not do certain things. The question of hospitalizations of under twos and so on, perhaps Unbin, who's a GP, and the colleagues from NICD can respond to that. And about the symptoms that are being seen at the moment, because they're the ones seeing the patients on a day-to-day basis. I can respond about the boosters. We are expecting a definitive recommendation from the Ministerial Advisory Committee on Vaccinations on further rollout of boosters. At the moment, the department is vaccinating healthcare workers who participated in the Sosonke study with Johnson & Johnson vaccines. So that's what we call a homologous boost. And we are awaiting the outcome, perhaps even this week, of an application by Pfizer to the regulator, SAHPRA, for the approval of use of the Pfizer vaccine for a boost. At that time, we should get an indication of what they are saying about it, but we anticipate that it won't be a problem for us to roll out in the same way that we did with the age categories with older people first with getting those boosters. But that we will know by the end of the week. And it's likely we will start with older people first with the boosters because they got their vaccination more than 6 months ago. So if I can hand over, I think colleagues from the NICD, I'm not sure who would like to tackle the first responses there. Thanks. Phaahla?
Thanks, Dr. Chris. So maybe I should just explain it more clearly that in the DATCOV hospital surveillance, we collect information on all the COVID-19 admissions. However, we don't do genomic typing on every patient that's diagnosed. So we don't know whether they have Delta variant or Omicron variant. But what we are trying to do is, because on the PCR test, there's a signal that you can pick up on patients who have the new variant. We can actually assign that signal to all the hospital admissions, and the ones that don't have the signal don't have the variant. The ones that do have the signal do have the variant. So we're working on that this week, and we're hoping to share that quite quickly. So I'm not yet able to share with how many deaths have been from the new variant, whether the children admitted have been with the new variant. I think that's something that hopefully during the next few days we'd be able to share more information on. But regarding the question about pediatric admissions and should you be concerned, we don't yet know if the admissions in children were precautionary or if they are more severe than they were before. But we do know that COVID-19 in children is usually mild, but we do have a few children who die, or we have had a few children who die, particularly those with underlying medical conditions like cancers and TB and HIV, and also the very young, children under 1 year. And so I think we should be cautious with children, as we should be with everyone, and to adopt the measures that we know to prevent transmission, including avoiding gatherings and, keeping distance, staying outdoors, wearing masks, and of course, vaccination. Thank you.
Dr. Crisp, did you allocate any other person?
Yeah, I thought maybe, thank you, Minister. I thought maybe Unbin would like to talk about the symptoms that they're seeing. He did mention it in the presentation, so if he's still with us, Unbin,
yes,
thanks.
Thanks, Dr. Crisp. Yeah, so I think, as mentioned in the present earlier, that majority of the cases that we've seen, so as general practitioners, we don't know what the variant is. And the clinical picture is pretty much the same as in the previous waves. So we've seen a lot of patients presenting with the flu-like symptoms, dry cough, fever, body pains, even night sweats. We're not seeing a lot of patients presenting with decompensation at the moment. But I'd like to say, obviously, this is still early days. In terms of the pediatric patients that we see, I think we do tend to be a bit more cautious with pediatric patients. And that also means that, we would refer patients a bit earlier for specialist care or maybe hospitalization, especially in the younger under 1 year olds. But the adults we are managing at home and with milder symptoms. Thank you, Dr. Crisp.
Okay, thanks very much. Minister, I think that's all the questions that were asked. We've covered. Thank you.
Back to Foster. I think we've dealt with all the questions. I'm just worried that I don't know if Tulio is still there. Would have liked to get some comment whether I know the colleagues from NICD dealt with, but just in terms of the link between the announcement in Botswana and their own finding, if you could also add if he's still there, but if he's not there.
Yeah, Minister is not there. They had to go to a meeting, both he and Richard. I'm sorry, I didn't send you a message.
Oh, okay. No, but I think the matter was dealt with by the team from the NICD. So possibly we can say that that's fine. I think we need to wrap up, and maybe Foster, you can get Dr. Lomo to come in.
Thanks very much, Minister and members of the panel once more. I think we've covered, we've responded to almost 95% of all the questions. The rest of the questions, we'll deal with them outside the formal media briefing as usual. So on that note, without wasting any time, I'm going to hand over to the Deputy Minister of Health, Dr. Songsen Dlomo, to summarize these discussions and so that we close. Over to you, Doc.
Yeah, no, thank you very much, Foster. I'm sure it's just that you like to hear my voice, but yes, I could actually start by thanking the Minister for really bringing such an eminent team of scientists to assist us. For me, it was more of a learning experience, and it is really assisting me, Minister, because we are still going to go out there with you being asked some of these questions, and maybe I was writing these questions and the answers, and I'll also be able to answer them in Zulu and in Xhosa sometimes, because this was mainly another language here that we used. The whole message from the Minister and the team were just emphasizing the president's speech to say Asigomeni. This Asigomeni is a song by Smith Black Mambazo, also encouraging South Africans to vaccinate. But Minister, I would really love to just emphasize on the 2 points. One was a question by Ukhaukhelo from UFM, who was saying maybe isn't it that we are maybe as a government having a fear-mongering approach when you talk about the fourth wave. Is to remind Ukhaukhelo that in fact in the presentation of Professor Abdul Karim Slim, he did mention that when he appeared before Judge Moseneke Commission, he mentioned that there will be a possibility of a fourth wave, and he did not mention the date and time. So we as government are always supported by scientists. And when we then started talking about the fourth wave, it was also based on that statement that him and other scientists have always advised us about. But the last one, Minister, and to the team is that the speech of the president yesterday, there's something that is asked by Mr. Brian Sokut. The president went on to say this travel ban or prohibition is not justified scientifically. Now, the president did not go as strong as Monyela is going through. The president remained very diplomatic on the matter. But if you listen to the AU co-chair, and that video has been playing in many of our national radio stations, where she had a BBC interview, Dr. Alakija. She mentioned a very emotional part there where she's mentioning a statement that in fact Botswana wanted to buy vaccines and somehow was pushed at the back of the queue by those who are rich. So you are now accusing Botswana for not vaccinating enough, and yet it wanted to vaccinate. We celebrate in the country, we wish you can do more, as the president was saying. We have vaccinated over 25 million, we have 25 million vaccines used. We wish you could have done more, and we will continue to do more. But in Africa, generally, the vaccine rate is very low, and not because they don't want, it's just because those who have money are jumping the queue and are ahead of all of us. So we wish that Monyela, and through your participation, you will be able to persuade these countries who are actually putting a travel ban on us, because they are actually dealing with bringing a big dent on the economy of the country and on just cordiality of the country. Thanks very much, Minister, for what you have done to us. And I'm actually ready now to talk about this matter in Zulu and English, because you are still going to get more South Africans who are asking about this thing. Thank you very much, Minister, and thank you, Mr. Foster. Back to you.
Thanks very much, Dr. Dlomo, our Honorable Deputy Minister. As usual, before I do the final closing, I'm going to request the Minister to give us that last parting shot. Minister.
Well, thank you very much. I just need to thank everybody, Deputy Minister, Dr. Crisp. And as we conclude, let me just, in front of the participants here, just to thank Dr. Crisp, who has been holding the fort for the last 2.5 months as the acting head. We did get a message yesterday through a matter affecting the DG, Dr. Buthelezi, which was handled under the presidency, that his matter has been resolved and that he will be coming back. So I want to take this opportunity to thank Dr. Crisp for having held the fort under very difficult circumstances. We'll still be with him, continuing in his other in his other roles as the DDG in the department, but and supporting the DG going forward. So thank you very much, Dr. Crisp. But thanks to all the panelists, indeed, I think it's very valuable, and I'm sure the members of the public have gained a lot from this interaction. No further ado, thank you very much, Foster. I'm sure you can close. Thank you.
Indeed, let me also thank the members of the panel for responding on a short notice, as usual, together with my key stakeholders, members of the media, for always being there for us, giving us opportunity to clarify certain issues that need to be clarified and also communicate the message. I want to assure the members of the public that as much as we do not answer all questions 100%, we are always available to respond to this question through media queries, through media interviews. We'll try to deploy as many messengers as possible. So on that note, I'm going to take this opportunity to officially adjourn this media briefing, but the communication will continue outside this formal media briefing. Thank you.
Thanks, Foster.
Recording stopped.